Welcome to Voice for Infection Prevention, where we explore the latest developments, challenges, and insights in the field of infection prevention and control. With a passion for promoting patient safety and healthcare excellence, we're excited to bring you engaging discussions with experts, leaders, and innovators in the field. So whether you're a seasoned professional or just beginning your journey in infection prevention, welcome to the conversation. This is Voice for Infection Prevention.
Welcome back to Voice for Infection Prevention. Today I have the privilege of speaking with Connie Cutler, a true leader in the field with over 40 years of experience in infection prevention. Connie's journey started in an unexpected way, working as a nurse's aide with a master's in biology, just looking to gain healthcare experience. That decision led to a lifelong career in infection prevention, where she has led teams through outbreaks, pandemics, and major shifts in healthcare regulations. In this conversation, Connie shares her insights on mentorship, team building, and hiring diverse infection prevention teams that include professionals from nursing, microbiology, public health, and data analysis. She also reflects on the evolution of infection prevention, the increasing regulatory demands, and how to balance work-life challenges in a growing field. Whether you're just starting in infection prevention or looking to advance into leadership, Connie's wisdom and experience offer valuable takeaways for anyone in the field. So let's get started.
This episode is sponsored by Clutch Recruitment, the leading recruiting firm in the country, recruiting exclusively within infection prevention and control.
All right, so I'll start this off same way that I do all these conversations. I'm curious if you're like most people that I've gotten to spend time with, did you just kind of fall into infection prevention, or how did you discover infection prevention as a field or as a career path?
Well, my background is both in biology and nursing, but I started in 1978, I think, working at a little hospital in rural Nebraska. And it's kind of a funny story about how I got the job. I was living on the East Coast. I got a master's in biology and then did not know what to do with that degree. I thought that maybe I would become a physician, but I didn't have any kind of clinical background. So when my parents were moving from the East Coast back to the Nebraska area, I decided I would go with them and see what life would be like in the Midwest. So I took my master's of biology resume into the little hospital, 46-bed hospital in rural Nebraska, and I said, I'd like to be a nurse's aide. And the director of nursing said, after looking at my resume, I have never hired anyone, Connie, with a master's to be a nurse's aide. Why do you want to do this? And I said, because I want to get healthcare experience. I want to find out what physicians do and what nurses do. And the only way to do so would be to work, quote, from the bottom up. And she said, okay, I will hire you and we're glad to have you. So I started in 78, I believe, as a nurse's aide. And for the first year, I was a nurse's aide working night shift, day shift, rotating, and mostly at a small hospital, I was working with RNs. And so the physicians would come across the street during the day shift most of the time. And so my interaction with them was relatively little. But I would see the nurses start the IVs and answer the questions and pass the meds and wash the newborns and do all of the things that I then learned how to do from the nurses. And there was an infection control nurse at the time. Her background was surgery, and she was nearing retirement, but she was not quite ready to retire. And at a small hospital, you get to know everybody. So she talked to me about how, as a surgical nurse, she understood aseptic technique, but she knew nothing about infectious diseases, public health, all of the background that IPs currently have. And so she said, I don't want to deal with Joint Commission. I'm afraid of Joint Commission. But what happened was she convinced me that if I became a nurse, I could take this role from her or from anybody. And with a biology background and a nursing background, this would be the perfect background for me. So what I did a year later was go to a accelerated nursing program in Omaha, Nebraska, and there weren't many at the time. Now there are a lot more with people with my background. And the same hospital hired me back again a year later. She had retired, and they said, guess what? You're a part-time infection control nurse and a part-time recovery room nurse. And I said, okay, great. So I had my foot in the door right away.
Awesome. Very cool. Okay. So obviously infection prevention has changed a lot, no doubt. But when you started in there as part-time, I assume you were the only IP at the facility, correct?
Yes.
So at the time, was that truly a part-time role, or is that something that very quickly absorbed all of your time?
At a 46-bed hospital, it was a part-time role. The funny thing, though, the Joint Commission manual at the time was a little paper, yellow, cardboard covered notebook that was about a half an inch thick. But infection control, as they called it at the time, was the biggest chapter in the Joint Commission manual. And I thought, well, this is important. And it really interested me. And so thankfully, it worked well for me to wake up the patients that were operated on in the morning. And then I had all afternoon to do the IP stuff. And so it worked well for 2 years. And I stayed at that role for 2 years. And then I wanted a full-time role.
Gotcha. So then at that time, did you have to go to a larger hospital to find a full-time role?
I did. I went, a colleague of mine from nursing school lived in Chicago, and she started to send me Chicago Tribune job ads. You know, we need an IP or infection control nurse at the University of Chicago, for example. And so that was one of my very first roles, getting that full-time job there. And so then I spent many years of my career in Chicago after that.
Gotcha. And then, so that first full-time role, were you by yourself or did you have a team?
No, I was not by myself, but there was only one other full-time person, and her background was public health. Really? And so the combination of public health and nursing was good, but this was a very complicated, large hospital on the south side of Chicago, and it was obvious that we needed more staff. And so it was very challenging to try to do what I needed to do. And so after about a few months there, I decided I would look around for another job. And so then I got my job at another hospital in Evanston, Illinois, which is a lovely suburb north of Chicago. And I stayed there for 9 years.
Okay. And then was that a manager role at that time?
It was. So I jumped right in from getting my foot in the door to management. And I had one full-time employee and a part-time secretary.
Wow. And how big of a hospital was that?
That one was 450 beds. And it concentrated, it was known for its thoracic surgery department. So we would have patients coming from all over Chicago because we had a great cardiac surgeon.
Okay. And like I said, obviously things have changed now, but I'm curious, when you first got into that role, was there, I mean, infection prevention is so expansive now. And so I'm curious, like, was it particularly expansive back then, or was it, I guess, when you started, was there anything that really surprised you, or was there any moment where you were like, man, I didn't realize I was responsible for that too, or I didn't realize, I guess, what was your, like, did you have any sort of eye-opening moments on that, or was it what you expected?
Well, what happened around that time period was HIV was discovered. And so that really was as shocking and scary to people as COVID was just recently. And so I was
Mhm.
dealing with a lot of public health issues and a lot of patients that were just afraid of getting HIV in the hospital, or a lot of healthcare workers that were afraid of taking care of patients with HIV who were sick enough to be hospitalized. And so that was something I didn't deal with in rural Nebraska. Not that it didn't happen there too, but it happened much to a much bigger extent in Chicago, obviously, with different patient populations. And so that was very eye opening because the fear of HIV was probably worse than the fear of COVID. Because in the beginning, there was no cure, there was no treatment, and there's still no vaccine for HIV. And so there was a great deal of fear of healthcare workers, which was one of my main targets to teach, about just walking into an HIV patient's room and will I catch HIV by bringing in the food tray, for example? Those were the questions I was asked.
Wow. Wow. So, man, so you had all sorts of things hit you at once. I'm curious, was there a moment? I mean, I guess when did you feel qualified to be in that role? Because I mean, there's not really an education that's focused on infection prevention. I mean, they're starting to be a little bit now, but certainly not at that time. So I imagine most of the job was learned as you were doing it. But was there a moment where you felt comfortable being the authority, or was there a stretch where you're like, I don't know why people are turning to me for this, but I'll do my best.
Actually, the certification process from CIBIC was developed the same year I went to that Evanston hospital. And I took the test, and I've always loved the challenge of testing. And so I thought, okay, this will help me prove to myself that maybe I'm competent. And so I passed the test, and I felt like, okay, certainly don't know everything about everything, but I also worked with two wonderful infectious disease physicians who were very helpful. And we were all young, we were the same age, and we were all kind of dealing with HIV, dealing with educating healthcare workers, dealing with just all of the issues with public health and the requirements to notify the CDC of every HIV patient we saw. And so it was maybe trial by fire, maybe, but we were in
Mhm.
it together. And so the camaraderie with ID physicians has been something I've valued my entire career.
Excellent. And let me take a step back too, because you said something that kind of surprised me. You mentioned you were working with a public health person on your IP team there initially, and I mean, I was under the impression that it was pretty much all nurses, especially at that point in time. So was that something that was uncommon? Did that surprise you to be teamed up with the MPH? And how did that work? I mean, did it work well at that time?
Well, it was funny at that first hospital I worked in Chicago. The public health person was the only one who could understand and deal with the physician. He was a challenge in his own right, and so he was one reason I left that hospital to go to the other hospital. He had had a revolving door of IPs, and nobody in Chicago wanted to go and work with him. So she was the only one that was able to tolerate him. Uh, and so that's why I was accepted from Nebraska to come to a big city hospital, because I was willing to work with him at least for three
Willing to do it?
months.
Yeah, yeah. Nice. Okay, so you had some exposure to the different backgrounds there. So we'll come back to that piece, but yeah. So you worked. How long did you say you worked as a manager?
Um, at that second hospital in Chicago for 9 years. And then for
Nine
the rest of
years.
my career, I was in management.
Gotcha. And then over those 9 years, how much did your role change?
Bit. It was interesting that that hospital was pretty innovative with its computer system. You have to remember that back then there weren't a lot of electronic medical records. We did a lot of paper charting and things
Hmm.
like that, and so my phone would ring in my office, and it'd be the Chicago Department of Public Health saying, John Smith is a patient in your hospital, and he has gonorrhea. Tell me what treatment he's getting. So I'd go to my computer and I'd look up John Smith and I'd say, where does he live? And they would tell me, on First Street in Chicago. And I'd say, we don't have John Smith on First Street. And they would be like, yes, you do. I know he's at your hospital because of the name of your hospital. And then finally, I would say, oh, you're talking about that other St. Francis Hospital, the one on the far south side of Chicago. You're not talking about mine. And meanwhile, they had already told me all about some patient I really have no reason to know about. And,
Oh, no.
I don't know who he is, but it was a real interesting time period. And so I got smart over the years I was there. And I would say, okay, are you talking about St. Francis of Evanston or St. Francis of South Suburban, whatever it was called? And they'd be like, oh, wrong hospital. So I learned to save a lot of time by just cutting them off at the beginning of the conversation before they told me all sorts of patient information they never should have told me.
That's good. That's good. And then what departments in the hospital were you kind of working with regularly at that time?
Actually, all of them. And that's what I have always loved about infection prevention. We had a hospital-acquired case of Legionella when I was working there. And so the water guy from the engineering department and I went up to the roof of the hospital and collected a couple gallons of water. And we sent it away for testing, and it came back Legionella. This was a typical Legionella patient. He was, a 75-year-old smoker with COPD, and he was sick enough to be there for past the incubation period. And so we had to report it to the CDC because there weren't too many cases of Legionnaire's disease that were hospital acquired. And so that brought in the CDC, that brought in all sorts of people to investigate, what we had to do to prevent the next case from happening. And so in those days, there weren't a lot of options. But later at a different hospital, I was one of the first to bring in a copper silver disinfection system for the water. So because we had a bone marrow transplant unit, and we wanted to make sure that the water for those severely immunocompromised patients was safe. So that's what I've always loved about infection prevention is you deal with housekeeping, you deal with engineering, you deal with food service, you deal with nurses, of course, and physicians and administration. So you really touch everybody. And I've loved that. Even though my background is nursing, I certainly consider it much broader than a nursing role.
Yeah, that's wow. I did not realize that it was that expansive that early on. So that's fascinating. So you said you had one person. Again, okay, talking about this. You're at a close to a 500-bed hospital. You said it was you and one person reporting to you. Now, like I said, now they're recommending one person per 69 beds, and then there's a new model now that's a little more descriptive. It looks like on APIC. But how did you do all of this with two people?
The role wasn't really considered 24/7 in those days. Neither of us had to take call. And it was mostly focused on culture results. So we would start the day with looking through the cultures that were done in our own lab. And we would go through them and say, oh, this patient's been here more than 3 days. Let's go read their chart up on the unit. We would start with what was in the computer, but it was not much in the computer. So we'd physically have to go up to the floor and read their chart and determine whether it was community acquired or hospital acquired. And so it was a lot of boots on the ground kind of stuff initially, but we didn't have the focus that much from external bodies other than every 3 years Joint Commission would come. So it was not quite the intensity of IP that is now, where somebody has to be on call 24/7. And
Mhm.
so that's kind of how, and the physicians were on call 24/7. I had two ID physicians and they would share call. So if they couldn't handle a question at 2 in the morning, they would occasionally, but I don't even remember more than one or two instances, reach out to me because they were very competent and they could handle 99% of the questions. And then they'd tell me about it the next day if it was something that I needed to follow up on. So it was good for my personal life because at the time I had two young children. So, it was hard to balance
Yeah.
family and now it's much more challenging. And so unless you have appropriate staffing, it's really hard to have any work-life balance.
Yeah. No, that makes sense. And then so after 8 years, you took another position. What position was that?
It was another managerial position at a 750 bed hospital. And
Okay.
the ID physician there was somebody that I was really looking forward to working with because we had the biggest salmonella outbreak in the country at the time in Chicago area. And if you go to the CDC and you look at how many cases of salmonella over the years, the last century, it was going down, 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 down until 19, I'm trying to remember the actual year, 1992, I think it was. And all of a sudden it spiked. And it was all because one of the milk distributors that made 2% milk had a problem in their manufacturing. And so the milk was not getting pasteurized and it was going into the
Wow.
bottles that were being bought by people who wanted to drink 2% milk. Actually, it was 1986. So I was watching him be interviewed on the news all the time. And I thought, oh, I like this brilliant, quirky ID physician. I want to work with him. And so in 1992, I was given the opportunity because I heard his manager was going to be leaving. And so I applied and I was hired. And then I spent the next 4 years working full time there. And then a merger happened. And you know how hospitals started to have mergers at that time.
Yep.
And so then I
Yep.
got to be the leader of 8 hospitals. And so things really took off from there.
Wow. And just for clarification, you were over 8 hospitals and maintained a manager title?
I did for 4 years. And
Okay.
finally, I said, I can't do justice to both roles. So I was looking for another job, and they said, oh, we'll keep you and promote you to the headquarters so you can be over 8 hospitals and not have also the focus of one large hospital.
Gotcha. Gotcha. And then, so when they promoted you to corporate, that's when you got a director title?
Yes. Hmm.
Gotcha.
But they
Okay.
also threw in, it was so funny. One day my boss called me in and she said, Connie, there's this other function called prevention of pressure ulcers. And so those are nosocomial, right? And I was like, yes, but they're not nosocomial healthcare issues. And she was like, well, since you understand nosocomial, why don't you also take on the pressure care group prevention? So I was given like two groups, the wound care group and the infection prevention group. And I was able to get them together from the 8 hospitals, and we made some nice improvements that reduced pressure ulcers. But it certainly wasn't my focus, and it wasn't my number one interest.
Yeah. Wow. Okay. So a lot of questions here. So when you were given when you jumped into the 700 or 800 bed hospital, how many people did you have reporting to you at that time, or how many people were on the IP team at that time?
Um, None of them reported directly to me. They all reported
Okay.
individually to their quality leaders, I believe, at that time. And so I would bring them together as kind of a best practice group. And my boss was supportive of standardizing our data collection. This was before, this was when NIS existed, not NHSN. So My
Okay.
hospital that I had worked full time in was a NIS hospital. It was a tertiary care hospital, and I reported data into the national database, but not every hospital had to report. In fact, you couldn't report if you were just a smaller hospital. It was just bigger hospitals that were sending data, and it was all voluntary. And
Oh, wow.
so I knew about NIS, and I was kind of concerned when I heard NHSN was coming down the road because we didn't have a lot of denominator data. In other words, for SSIs, we had wound class, and we had ASA score, and then we had length of surgery. And that's really the basic information we were collecting on our patients who had total hips, for example.
Hmm.
And so I was worried that a surgeon, an orthopedic surgeon who had severely ill patients, older patients who might have a worse outcome with higher SSIs would be adversely considered a worse physician. And the reality was he wasn't a worse physician. He just had sicker patients. So I was a little hesitant when NHSN was being considered as something that we would be judged on
Uh-huh.
until, and I was able to feed back my concern to the CDC. And so it kind of slowed out the rollout of NHSN for a couple years. And they included more things in the denominators after time, like the age of the patient. The length, the same three things were part of it, but they added more criteria such as age and made it a little fairer to the surgeons if we were comparing surgeon A to surgeon B.
Gotcha. And then, so tell me this: you transitioned from being over one person, single facility, to now, I mean, and at 4 initially, but then over 8. How different was your job being more, I imagine, more boots on the ground initially to now being more oversight and kind of process oriented?
Actually, it was something I really loved because I had colleagues that were newer who had started in their local hospitals, and I was able to act as a mentor. They could call me up and say, "Hey, Connie, we got this culture result that I don't understand." And since most of them were nurses, microbiology was not one of their skills. And since my background was a master's in biology and I had done microbiology work, I was able to say, that's a very sensitive organism. It might sound scary, but it's not something that we consider abnormal at all. And so I was able to kind of be someone they could pick up the phone and ask a question to without feeling embarrassed. And
Hmm.
so I loved that mentorship role, which started probably at that time period. I also had colleagues who were as seasoned as I was. And so I relied on them at the other large hospital to kind of help me with best practices that we could put throughout the entire network and raise everybody. And so it was a great role to have for many years.
Gotcha. Did you feel like you were prepared for it from a management skill set thing? I mean, it feels like jumping from being over one person to now, I mean, multiple facilities with multiple cultures and groups of people. And was that intimidating for you, or was that something that you just took in stride, or
Yeah,
what was that
I took it
transition
in
like?
stride. If you ask my kids, they're like, "Oh, mom, you're always somebody's boss. You were first our boss, and now you're other people's boss." But even though they didn't report to me, I felt like I had the leadership skills and just the ability to enable them to trust me. And I relish that. I really like to educate and teach and encourage certification. Since I was certified, I wanted all of my IPs to be certified. And so I promoted that. And, that required studying and maybe getting together in small groups. And so we did some of that. And since biology was my background, it was easy for me to help with that chapter on microbiology that scared most of the people at the time.
And how at this time, how aware was everybody at the hospital of the infection prevention department and the infection preventionists? I know, like, you talk to different people, and I mean, it just sounds like just 10 years ago, there are people in the hospital don't even know who the infection preventionist is, or they don't see them because they're behind a desk. I mean, how popular is not the right word, but I mean, how aware were people at the hospital of this infection prevention department and team that's working to do these things? Were you out there, or was it kind of in the background that people
Well,
had to
when I
kind of
was in
find you?
this role at the aide hospitals, I would go to the aide hospitals and I would tell the IP, I'm going to show up on Wednesday and I want you to take me around the hospital and introduce me. And I don't want you to say, somebody from the corporate office is coming. I want you to say, here's somebody with background that can help us. And so I never liked feeling like a cop. I always purposefully pushed that role down and I wanted to be seen as a consultant. And I think that led me to being somebody that people would not fear, but
Mm-hmm.
value. And so I would come often enough. I think once every other month, I'd visit one of the hospitals and I got to know some of the staff because I would go to the different floors with the IP. And sometimes the IPs were not out on the floor very much. And so I encouraged them to be the same kind of consultant role that I like to model so that they,
Mm-hmm.
when they would walk up and, we sometimes had clipboards and we were watching hand hygiene, and that to me is a cop role. And so I kind of encourage them to go up and be more, I noticed that you're about to go into that patient's room. And would you please use hand hygiene before you go in the room? It'll protect both you and the patient. And I would preface it by saying, gloves, I know you're going to wear gloves because you're starting an IV, but gloves are not perfect. You have to protect yourself and the patient because about 10% of gloves can have microscopic holes in them. And people would be like, oh my God, really? They're not 100% protective? And it'd be like, no. So, use hand hygiene so that you are protecting the patient and you are protecting yourself and your child at home or your grandma. So I would try very much to bring it down to the personal level so they would understand infection prevention helps the patients and helps the healthcare worker. And so that was kind of like the major message I wanted to get out. And by saying that to the IPs that were showing me areas in their hospital, it opened up a lot of doors that might have been closed in the past. In fact, I remember at one hospital, they were getting ready for a survey, and the guy in EVS said, Connie, I'm going to unlock this door that I don't plan to unlock for the Joint Commission, but I want you to see it. So he unlocked the door and took me in and he said, so we have storage of this on the left and storage of this on the right. Is that appropriate? And I said, no, it's not appropriate. You have to have clean on one side and dirty in another room, preferably, not just in the same room. And he was like, that's what I thought, but I wanted to get your opinion, and we'll take care of it. We'll move it, but I don't plan to show Joint Commission this. I just wanted to show you. So I felt like that was a positive feedback that I received.
Yeah.
And so I would always walk in and say, I'm someone here to help you. I'm not here to ding you. That's what Joint Commission does. But I want to get you ready. I want to help you. I want to improve your care of patients because we're all in this for the same reason. And
Yeah.
I think having that philosophy has served me well.
No, it's great, and I want to stay here for just a second. I've talked to somebody here recently. I forget who said it, but they kind of had a rule for their new IPs, and it was never carry a clipboard, and that one of the reasons is exactly what you were talking about. So I'm just wondering, like, speaking today, if you were talking to somebody that was in the role or had done it, do you have any quick things that are like, be sure to do this and not do this when you want to not appear as a cop? I mean, I feel like IPs are fighting against that that all the time. So do you have any quick things to do or not to do that will help present the consultative role and partnership role that you really want to be seen as?
At my last big hospital I worked in, I had 8 IPs, and we divided up all the units by IP. And I would say, one of the best things you can do is show up for their rounds and just be there and listen. And then they look at you like, oh, you're not a stranger. You're somebody who's here to help us. And once in a while, something would come up as they would go and describe patient by patient why this patient's here, what the plan is for that patient. Once in a while, the IP would have something good to add. If it were a tuberculosis patient, for example, they would say, well, the health department says you need to have one more culture before that patient can go home. So they would interject something that would be helpful to both nurses and physicians while they were there, and they would be seen as a part of the team and not just an outsider. So they would try to get to their units at least a couple times a week, and that way they're considered part of the team. They're not just strangers.
Yeah. Okay, that's great. And I'm looking here. So you did this for a while. You ended up taking another role um, as a director, and it looks like so you were over infection prevention and wound care and some different things. Then you took another role as a director, and you had employee health under you.
I did.
Have you always had employee health? Has that always been a thing? Or was this new for the role at Swedish?
Well, I'd always interacted with employee health because of needle sticks, for example. And back in the HIV days, people were afraid for their future, for their safety, for their life if they got an
Mm-hmm.
HIV needle stick. And so I always would interact with healthcare workers who would sometimes come to me and shut the door and say, okay, I'm married. Do I need to sleep in a separate bedroom? Do I need to wear a condom? Can I get pregnant? They would ask me very personal questions because employee health wouldn't always read the same studies I was reading. So I would work very collaboratively with employee health. And I had proposed at that large hospital system that possibly employee health would report to me.
Mm-hmm.
But at the time, they had a director who was very adamant about, no, we want to keep it separate. And so, plus, I also had a change in a boss. And so, there were a couple things leading me to leave that system to go to a system where I could be a director of employee health. It wasn't my goal in life to do it, but I understood that I had 2 nurse practitioners that were great in employee health. And so I would help them with the infectious disease, infection control part of their job. And they would do the new employee physicals and that stuff. So we worked very well together. And so I stayed there for almost 3 years until I got recruited to the East Coast.
Okay. And so this is really fascinating to me because when from the recruiting end, when I go and I try to search, and sometimes we'll get jobs and employee health will be part of it. And it is very common for one of the first questions that I get from a candidate that is initially interested is, will I cover employee health too? And if you say yes, then they are no longer interested. So the fact that you pursued a job because you could do employee health as well is just not something I'm used to hearing at all. So I'm curious. So when you got into that role and you started doing both, was that something that worked well? Was that something that took up too much of your time? I mean, did it work how you thought it would? I mean, should they be together or should they be separate?
It worked well most of the time because, as I said, I had 2 full-time nurse practitioners. And so they knew way much more about new employee physicals and, all of the onboarding things. The challenging part of employee health at that hospital was that they also did workers' comp. So that was the worst part of the job, was the workers' comp. If workers' comp is outsourced, then employee health fits in very well with infection prevention. And when I would go to my committee meetings, I would wear two hats. I'd say, okay, here's my infection prevention report, here's my employee health report. And so it was, there were a lot of reasons that it made sense to do both jobs, but the workers' comp part was the worst part.
Yeah. Okay. Um, I'm curious with today, with how infection prevention is today, is there enough time in the day to do both infection prevention and employee health? Or would it make more sense for there to be two kind of director level people, one over employee? Obviously, you're working together, but one doing employee health and one doing infection.
I think it'd be hard today to do both because the requirements of infection prevention grow all the time. And in those days, I could do both because I had a great group of nurse practitioners working in the employee health section. But if you're a single practitioner at a small hospital and you have two hats to wear, I think that'd be real challenging unless it's such a small hospital, like a critical access hospital where you have 30 beds or something like that. So
Mm-hmm.
I think it's just gotten too difficult to wear both hats now.
Yeah. And you've obviously, I mean, let me ask this. I mean, you've been in the infection prevention, career field for over 40 years now. I want to know how have you stayed in it? I mean, you've gone through several pandemics, outbreaks. I mean, you've seen it all. Obviously, we faced a ton of burnout during COVID, and which caused a lot of people to leave. But I want to know from you how did you stay in it? I mean, what kept you encouraged? How did you avoid burnout?
I love this field. I always have. It hits me as something that I can protect healthcare workers, I can protect patients, and I can use my expertise to improve care of both groups. And so I've loved the fact that there's never a dull day. I'm somebody who's a continuous learner or whatever that phrase is, and so the worst thing I would ever say to myself was, it's been kind of quiet lately. If I would say that, then there'd be a new pandemic. So I learned over the years to enjoy the quiet periods because something's going to happen. And as we know, probably as we encroach on various parts of the world and more pandemics are going to happen because humans are not supposed to go into those bat caves and things like that where we go now and bring back these organisms where they can get out into the public. And so I've enjoyed the the fascination with this ever changing field.
Oh,
I've loved to educate and I've loved to mentor, and so over the years, that's why I stayed with it. Just a brief story: when I went to my 800 bed hospital in northeastern New Jersey and left 2 years ago, 2.5 years ago, the IPs there in January of 2021 were exhausted. That was
mm-hmm.
the height of COVID, and they hadn't even had a day off. And I said to them, okay, you get a 3 day weekend. Then next week, you get a 3 day weekend. And they were like, you really? We can get time off? And I said, of course. You're no good to yourself. You're no good to your family. You're no good to the patients if you are physically, emotionally exhausted. You need time off. And so they were so thrilled that I came there as an interim that the network actually said after my 5 months and they hadn't been able to find somebody, they said, we want you to stay. Would you become permanent? And I was like, yeah, I'll have to move from Chicago. It's a lot of hassle, but okay, I'll take you through the next year and 3/4. So I had already known my staff for 5 months, and it was so funny. I remember one night going to sleep and saying to myself, wonder if it'll feel any different the next day when I go to work because I'll be in the same office, but now I'm an employee. And honestly, it
Yeah.
didn't feel any different other than I got paid differently. So,
Yeah.
but I love the field and I love to help both the IPs and the healthcare workers and the patients.
That's great. And you've obviously, I'm between your consulting work and your interim work and then all of your leadership positions. I've no doubt you've set in on a ton of interviews and interacted with a ton of IPs. I'm sure you've seen people come into the field and leave the field, and you've seen people get into it later in their careers and early in their careers. I mean, you've seen it all. But I'm curious: is there any, I don't know, like personality trait or particular skill set that you see in somebody that you're like, okay, you're an IP. I mean, you're gonna make it in this field. What do you, when you're interacting or interviewing, what do you look for, or what is that trait that seems to be common amongst all of you guys?
I think it's a curiosity to keep learning. Um, I've thought about infectious disease docs since I've worked with them my whole career versus, let's say, a cardiologist. A cardiologist knows everything there is to know about the heart. An ID doc has to know everything about where a patient has traveled. Do they have birds? Do they change the cat litter? So it's that questioning detective kind of attitude that I'm looking for. And I've hired floor nurses who would be very interactive with the IP. When the IP would come to the floor, they'd be like, "Oh, I have a question for you." So somebody who has that curiosity and wants to learn is someone that I consider a future IP. Someone that's happy just with their 7 to 3:30 shift and wants to go home and not think about anything for 24 hours. I don't think they have the right curiosity to be an IP. So background, and it's harder and harder to find people with IP backgrounds to hire. So
Mm-hmm.
I've hired actually an intern that was at the University of Pittsburgh that had done some internship there in IP. So I, of course, look for IP backgrounds, but since that's hard to find, I look for people who have the curiosity and the willingness to realize this you will be learning for your entire job. This is not something you'll ever feel 100% competent in, even if you're certified.
Yeah, no, that's a great answer. And along the same vein, I'm curious if you were to walk into a hospital and maybe their department's empty, or they've struggled with things, and you were to kind of put together your like IP dream team. When it comes to educational background, do you have a preference towards nurses or non-nurses, or what? How would you shape that team if you had whatever option out there for you?
I think if I had, let's say, the opportunity to have five IPs, I think I'd probably like, oh, two nurses, one microbiologist, one MPH, and somebody that had maybe a um, background in terms of policies and procedures or something like that, because
Hmm.
everybody brings skills. And I always thought that a team with various backgrounds would be the best team to have. And I've been fortunate to have teams that are varied. And as I said earlier, to bring a microbiologist up into a patient's room is kind of scary for them. I actually had a microbiologist to say, I like to see it in a cup. I want you to bring it to me in a cup. I don't want to see it coming out of the patient, whatever
Yeah.
specimen we're talking about. So everybody brings their skills to the department. Whereas an MPH would be like, oh, yeah, I can run a research project and I can collect data and I can make great graphs. Whereas a nurse maybe can't make great graphs and maybe doesn't understand statistical significance. So having people with varied backgrounds brings the whole team up. And so and the nurses should be willing to take a microbiologist with them to say, okay, here's how you check the urinary catheter to see if it's hooked to the leg. You have to lift up their gown and you have to look at their leg, but you can do this, just to have
Yeah.
somebody there with you. So the skills of a varied team is the best.
Awesome. No, that's great. And as a closing thought, I kind of want to open the floor a little bit for you to speak. I mean, you know that most people engaging with this are going to be people that are entertaining the idea of an infection prevention career or somebody that's trying to actively grow in their career. But I'm just curious if you have any words of advice or anything you could share with them just to encourage them or excite them about the field in general.
I would say that it's a great field. There's never a dull moment. And if you're somebody who likes variety, this would be the field for you. Um, and try, if you can, to work in a team environment, because I think that's the best learning experience that you could have. I understand that there are still, single hospitals that have an IP that maybe wears several hats. Nursing homes where the IP is also the director of nursing, and I don't think that's a good idea. So try, if you can, to get your foot in the door at a hospital or healthcare institution where there's somebody you can learn from and learn with, and also join your local chapter. When I was at my very first hospital, I joined the Omaha chapter, and I would reach out. I'd be like, okay, I have no idea what to do about this situation, and somebody would be helpful. And, these weren't people that I was necessarily working with, but we were all in the same boat. So I really do advise APIC membership, and just the idea that it'll be a great career. You'll learn so much. And yes, some of it might be scary, but if you live through something like HIV, which is my first scary disease, that you can bring that knowledge to Zika, you can bring that knowledge to H1N1, you can bring that knowledge to COVID, and you can help healthcare workers who are younger, who've never had something where, oh, if I go in this room, I might catch that disease and die. You can help them understand that personal protective equipment is important, following the guidelines is important, and the IP is on your side. We want to care for the healthcare workers in addition to the patients. And so you really have two audiences. And don't forget that those ID physicians are your best friends. They're the ones you go to with questions about, is the patient on appropriate therapy? I see a resistant organism on this culture result. Should that patient be changed to a different antibiotic? And they can educate you about how there aren't a lot of choices for antibiotics nowadays. And so being collaborative and understanding that we are all in it to improve patient care and healthcare worker safety is kind of the reason to want to be in this field.
All right.
Thank you for joining us on this episode of Voice for Infection Prevention. We hope you found our discussions informative and insightful. Remember to subscribe to our podcast for more conversations with experts in the field, and don't forget to leave us a review to let us know what you think. For additional resources and to stay updated on the latest news in infection prevention, visit our website at voiceforip.com. Thank you again for listening. Until next time, stay safe and continue your commitment to excellence in infection prevention.